Greetings and welcome to our monthly webinar hosted by the Institute of Public Health, UAE University. I'm Dr. Rami, faculty member at the Institute of Public Health, and this webinar is a part of the global initiative known as This is Public Health, which aims to shed light on various critical public health issues, particularly the emerging public health issues. We are honored to have affiliations with ASFER, the Association of Schools of Public Health in the European region, and with IFA, the Emirates Public Health Association. Let's go over a few housekeeping items before we welcome our speaker. So throughout the webinar, you are encouraged to ask questions, and to do so, simply click on the Q&A option located at the bottom center of your screen. Feel free to submit your questions during the presentation, and we will address them at the end. Please note that this webinar is being recorded, and the recording will be available on our YouTube channel, the Institute of Public Health CMHS, where you can also find recording of our previous webinars. This webinar has received accreditation from the UAE University as 1 CME Category A. Therefore, at the conclusion of the webinar, we will provide a link in the chat box for you to evaluate the webinar. Your feedback is priceless, and by completing the evaluation, you will receive your CME certificate of participation. Now, it's with great pleasure that I introduce today's esteemed speaker, Dr. Emma Davies. Dr. Davies is a consultant clinical scientist currently based at Manchester University in UK. She has been in her current position since October 2022 after gaining fellowship of the Royal College of Pathologists in 2019 and completing the higher specialist scientist training in 2021. She has a particular interest in molecular diagnostics and whole genome sequencing from the laboratory perspective, alongside an interest in viral infections in pediatric patients, particularly those who have undergone hematopoietic stem cell transplantation. The title of her presentation is Emerging Zoonotic Diseases, Case of Monkeypox in Europe. Dr. Davies, the virtual floor is yours. Thank you so much.
Thank you very much, everyone, and thanks for taking time out of your evening to come and hear me speak this evening. So I'm just going to share my screen and we'll get started. So as introduced, I'm here to talk to you today about emerging zoonotic diseases and a little bit of a slant on the title, but I am going to talk about a case of Mpox in the UK rather than in Europe, which is where my sort of area of specialties lie. So monkeypox virus, so it's first discovered in 1958, and that was in research monkeys that had been transferred from Singapore to Denmark, hence where it gained its name, monkeypox virus. The first human case wasn't found until 1970, where it was discovered in a 9-month-old young boy in the Democratic Republic of Congo. And in between 1958 and 1970, there were a number of laboratory-based outbreaks which involved monkeys. Yeah, so the first human case in 1970, it was thought to have actually started to emerge as sort of immunity to smallpox waned as the smallpox eradication efforts sort of progressed. So monkeypox virus, it's part of the family Poxviridae from the genus Orthopoxvirus and species monkeypox virus. But however, in November 2022, the WHO decided that monkeypox virus was no longer an appropriate name with which to be referring to this. And so the disease itself became known as Mpox. So for any of you that have got particular interest in virus structure, the picture on the right is a picture of sort of a monkeypox virus. It's sort of block-shaped virus, and it's unique in that it can be seen under the light microscope, which is really unusual for a virus. Okay, so it's a double-stranded DNA virus, and it's got a genome of about 190 kilobases. And as I've already said, it's related to smallpox. Some of the other pox viruses that you might know that it's related to are sort of cowpox, camelpox, Alaska pox, One of the things that it's not related to is chickenpox, and that is a common misconception. Chickenpox is actually a herpes virus rather than a pox virus. So we always think of monkeypox as being a sort of zoonotic virus in origin, but we don't actually know which animals that it comes from. We can often find it within rodents and small mammals, and there's often been outbreaks associated with sort of the Gambian pouch rat, which is the picture you can see in the middle there with that animal that's wearing a leash, or African squirrels and dormice, and even there's been outbreaks associated with prairie dogs in the USA, and that's probably one of the most well-known outbreaks outside of Africa. It was actually the first extensive outbreak of monkeypox outside of Africa, and it came from the export of about 800 small mammals from Ghana over to a small mammal facility in the US, and that resulted in 47 cases of monkeypox across 6 states in the US related to actually receiving bites from pet prairie dogs. So when we think about monkeypox and we think about its epidemiology, it's actually the most predominant cause of orthopox infections and outbreaks since smallpox was eradicated back in the late sort of 70s, early 80s. And between 2000 and 2021, there have been 95 suspected outbreaks, but 40 confirmed in the Central African Republic. And early on in 2000, they were primarily outbreaks that occurred in sort of young children under 4. But as time has gone on, they've evolved to involve young adults as well. And again, this is down to a loss of immunity from patients no longer receiving smallpox vaccination as part of their routine childhood schedule. It's been endemic in Central and Western Africa for a long time, and there have been thousands of cases reported annually in the Democratic Republic of Congo since 2005. And it was seen back in Nigeria prior to 1990, but did go away and then has re-emerged in Nigeria in 2017. And that has been one of the largest outbreaks we've seen prior to the one that I'm going to focus on here. And between 2017 and 18, there were 122 cases of Mpox disease in Nigeria with a 6% case fatality rate. And so if we look at the progression of monkeypox infections over time, so before 1990, there was quite a spread across sort of Central and Western Africa as far out as Sierra Leone. However, between 1990 and 1999, they were sort of focused primarily in the Democratic Republic of Congo and the Cameroon. And then again, as we move further forward between 2000 and 2009, that spread has widened again to include the Central African Republic and Congo and the DRC. And again, between 2010 and 2017, cases in Africa have been expanding out to cover a much larger geographical region within Africa again. So looking at the UK specifically, we never saw any cases of Mpox in the UK before 2018, but between 2018 and 2021, we observed 7 cases of Mpox in the UK in total. So over that time, 4 of these were imported, and they represented 4 distinct imports into the UK. So there was a single case that was imported from Nigeria in the beginning. A second case again reported from Nigeria, which then went on to infect a healthcare worker who was thought to have picked up Mpox infection from cleaning contaminated bedding before the infection was picked up. There was then a further case a little bit later on, and then a final case which actually led to a cluster where 2 of their household contacts also became infected with the virus. This healthcare-associated contact from that second case that was imported has been the only UK documented healthcare worker acquisition. And so it is thought that overall the risk to healthcare workers is low. And despite having had these 7 cases, there was actually no documented community transmission within these outbreaks. So sticking with that theme of sort of a zoonotic transmission with very limited community spread. But then in May 2022, something strange happened. So on the 6th of May 2022, the UK found a single case of monkeypox infection that was associated with travel to Nigeria. So the patient had developed a rash on the 29th of April, presented to hospital in the UK on the 4th of May, and it was thought to be an isolated case. Not very long after that, a second incident occurred, but the most alarming thing about this particular case was that there was no travel associated with this patient. Then again, not long after that, there was a third cluster of activity, mostly associated with gay and bisexual men who have sex with men. And it was then apparent to us that there was ongoing community transmission. So the WHO declared what they considered to be a public health emergency of international concern on July the 23rd of 2002. So when we're looking at the UK, so the UK, in England, we had our first case on the 6th of May 2022. Wales and Northern Ireland both reported their first case on the 26th of May, and Scotland followed on the 29th of May. So if we think the first case was the 6th of May 2022, by the 8th of June, the UK had reported 336 cases. And by the 7th of July, so just 2 months later, over 1,500 cases had been reported in the UK. And that's a significant upturn in activity, which really does tell us that there was something a little bit different about what was going on with these importations at that time. If we look at sort of the global cases that were being reported around that time, in August 2020, there was a global peak of 31,075 cases that were reported in that month alone. And when you look back over historical data between 1970 and 2022, only 38,025 cases were reported in Western and Central Africa throughout that time. We do have to take that figure with a pinch of salt, because the access to diagnostics, particularly over that time, may not have been particularly good. And also a lot of the diagnoses would have gone unreported, particularly those that were clinical. But it just goes to show the scale of what we were dealing with at the peak of this sort of unprecedented outbreak that we were seeing. So what was the difference? So when you look at monkeypox and its sort of genetic makeup, it's split down into two clades of virus. So we have clade 1, and that was formerly the Central African or Congo Basin clade virus. And that has remained primarily restricted to causing infections in Africa, except for these exportations that we see from time to time and do still see now. So in the UK, we consider this to be what we call a high consequence infectious disease. And that's a disease that has the ability to go on to cause significant adverse effects in an area where it is not currently spreading. And this clade of virus, it has a case fatality rate of 10%. So in about 10% of cases, it's going to be causing mortality. There is also a second clade known as clade 2. So it used to be known as the West African clade, and that's been split down further into clades 2A and 2B. So clade 2B was found to be responsible for the global outbreak that we saw in 2022. And primarily we were seeing what we call lineage B.1 within the UK. And what that was actually found to have was a mutation rate that was significantly higher than we were seeing in any other Mpox virus that was circulating at the time, which suggests that perhaps it's had time to develop virulence factors or specific sort of traits that allow it to spread more effectively, and whether that is through causing more rates of asymptomatic infection, it's not particularly clear. One of the good things is that we don't consider this to be a high consequence infectious disease in the UK anymore, and the case fatality rate is extremely low. So for clade 2A, there's documented case fatality rate of sort of less than 3%, but luckily for clade 2B, Some of the work that's come out over the last 12 months has actually shown that the case fatality rate is as low as sort of 0.016%. So really, really rare to have deaths associated with this, which is good news when we look at the sort of numbers of infections that we've been seeing. So who was infected or affected as part of this? So we talk a lot about transmission in the gay, bisexual, men who have sex with men community. And they were the primary focus of certainly the beginning of this outbreak. However, we did see cases noted in all ages and sex across the UK. And I think that this was a picture that was shown sort of worldwide as well. The transmission seemed to be sustained within the GBMSM communities, but women and children were found to be sort of household contacts, but did occur as sporadic cases. So the WHO have collated this data, so between the start of the outbreak and up until November 2023, and you can see here, this is the proportion of cases who were MSMs. And again, very near the beginning, sort of close to 100% of cases, but dropping in the middle down somewhere when you're looking at confidence intervals down to around 50% of cases, which does show that we do need to be thinking about this as a cause of disease in almost everyone, even though those numbers have come back up close to 100% in recent times. So what did we see overall globally throughout this outbreak? So overall, 92,783 confirmed cases with 171 deaths across 116 countries. But we have to be mindful that these are reported figures, and these are going to be in areas where there are good reporting systems with good diagnostics, and also in patients who are presenting with symptoms or presenting to healthcare at all. And so the true numbers are likely to be much higher than what we have seen reported here. And you can still see now, so the latest figures that are available are for November 2023. And we're still seeing a significant number of confirmed cases across a lot of countries, so 906 over 26 countries, but luckily only 4 deaths associated. So where's been most affected globally? So you can see here that these are sort of areas of the Americas and within Europe, with the US reporting significantly more cases than anywhere else. And again, this could be down to the diagnostic possibilities or capabilities available in some of these countries. And of interest there, China is number 10, which is reporting 2,024 cases, but they didn't report a single case until January 2023, which seems unusual. Yeah, these 10 countries, they account for about 81.4% of reported cases across that time frame. So looking at the epidemic curve for total of cases that have been reported since January 2022, you can see at the very start of that graph, no real cases notified. However, as the UK reported that first case at the end of April, start of May, that number shoots up, and that's likely down to the awareness and sort of global media attention that brought with it. And so we were seeing at the beginning, particularly large numbers of cases reported from the Americas and the European region. And as you can see, tailing off on that graph, the Western Pacific regions and Southeast Asian regions don't really start to appear until into 2023. And again, there you can see sort of in July, that peak in the number of cases at just sort of over 30,000 cases for that month, which is alarming when you look at that pre-global outbreak. So when we start looking at global deaths as reported up to November 2023, again from January, there were some sporadic deaths reported pre-outbreak. And luckily, again, those numbers do remain small, but there was significant sustained numbers of deaths, mostly reported again through the region of the Americas. But if we look back at that reporting, that's where the majority of the cases were being reported from. And so it's not beyond the realms of possibility to think that that may be the cause for that sort of high numbers of deaths across those regions. And again, you can see here that that green sort of Western Pacific region doesn't start to appear until sort of very late on in reporting. So if we look at the UK specifically, so the epidemic curve for the UK specifically, you can see that we've got this sort of gradual increase from that first notification of case at the end of April. And that went up to a weekly peak of about 350 cases in July 2022. And that is probably due to the lag. So we were advised to start introducing measures to reduce spread sort of near to the end of May 2022. And you can see then that gradual decline down through August, and then a low rumbling of numbers seen in the UK. Along up until the end of December last year. So looking at those numbers in more detail, so you can see here from this table that the majority of the cases have been reported out of England. So the devolved administration, so Northern Ireland, Scotland and Wales, have all managed to keep their cases very low, all under 100 cases reported. The first column shows cases reported in 2022. So again, significant numbers associated with that first outbreak. And we are still seeing some cases in 2023. So Northern Ireland, Scotland and Wales, amazingly only showing a total of 5 cases across the whole of 2023, which is fantastic. In the UK, we are still seeing higher numbers, but they do appear to be both imported and acquired within the UK at around about equal measures. Those numbers that are coming from England are likely to be there's likely to be much higher associated with probably with outbreaks of Mpox disease in GB/MSM communities in London, where we saw very high numbers. So when we're thinking about Mpox, when we talk about we'll go through now and we'll talk about the clinical presentation, the management, etc., just so people still know what to be looking for. So clinical presentation. So once somebody's had contact with a case of Mpox, the typical incubation period is around 5 to 21 days. But it can be longer than that. So prior to the Mpox 2022 outbreak, it was often thought that 21 days was the longest period of time where we would expect symptoms to appear. However, it's now become clear that that can exceed 4 weeks in some cases. So we often find that disease is supposed to start with a fever, and then the rash appears sort of 1 to 5 days later. And it's always been said that lymphadenopathy is a really common characteristic of Mpox disease and can be used as a differential when you're doing a clinical diagnosis for Mpox. So with rash, it normally starts on the face and then begins to spread elsewhere. However, you can get isolated genital lesions or isolated oral lesions. So don't exclude people with sort of single lesion rashes. UKHSA in the UK spent a lot of time making up posters to sort of alert people to the symptoms, which were sent out into areas where people might not necessarily have as much experience of dealing with diagnosis of Mpox. So using them in sexual health clinics and in ED departments, so emergency departments, and they were also used on social media to alert people to the fact that they should present. So the rash, you often get lesions, monkeypox lesions that appear that are all at the same stage of infection. And that again is different to chickenpox, where you end up getting lesions spread, which start on the face and then spread. but will be at different stages of their vesicular nature. So with monkeypox as well, it starts on the face, usually if you've got multiple lesions. However, it then spreads to the hands, the palms and the soles of your feet, which is a little bit unusual again for chickenpox, so another good differential. So here's just some images kindly taken from the UKHSA, just showing the progression of monkeypox lesions over time. And so each of these stages sort of takes between 2 to 4 days to get through. So you start off with an early vesicular lesion, which then progresses to a small pustule, and then they umbilicate in the middle. And again, that is different to how chickenpox lesions go. They can then go on to ulcerate and form this black crust over the top, and then they form mature lesions, and then the scab part falls off. And it's only once that scab is removed and a new layer of skin is formed over that the person can be considered no longer infectious. So going back to what I was saying previously about sort of this classic triad of diagnosis of monkeypox. So we always think of people with a fever, a rash, and a lymphadenopathy, and that is a pretty good way to clinically diagnose monkeypox infection. However, WHO did collect some data, and this is only a fraction of the cases. So this only looks at about 37,000 cases, but you can see that about 90% of people had any rash. However, fever only associated with sort of 58, and that lymphadenopathy comes right down there at 30% for any lymphadenopathy, 21% for general lymphadenopathy, and 15% for local lymphadenopathy. So really important to still consider, even where you don't have that classical triad of disease symptoms. So yeah, and so a whole range of different symptoms reported that you wouldn't necessarily consider when thinking about monkeypox. So once you've got the rash or the disease, so it is usually self-limiting and resolves within around about 3 weeks, but you can get this prolonged duration of lesions, although they usually last on average around about 10 to 12 days. As we previously stated, you can get deaths occurring, and that's most common in those clade 1 viruses, but very rare in the clade 2b viruses that we tend to see outside of Africa at the moment. One of the things that is a worry is you can get permanent scarring as a result of having had infection. And this can be particularly challenging around areas like the pharynx or around the penile tissue, where they can cause strictures and go on to cause significant sequelae down the line. And so it's in those cases where we might want to think about managing those less conservatively than we might for a case of mild monkeypox. We've got usual people who are at severe risk of severe disease. So we've got children, pregnant women, and immunosuppressed patients, again, who we need to be that little bit more careful about when we're thinking about how we manage these patients. And complications, they are relatively common. So secondary bacterial infection of lesions is quite common, with some papers reporting sort of 60% of patients requiring admission to hospital due to secondary bacterial infection. And proctitis is another common reason for admission to hospital. The other complications there, they do exist, but they are less common than something like a secondary bacterial infection. So how do we diagnose monkeypox infection or monkeypox virus infection? So once upon a time, it would have been done clinically or by perhaps electron microscopy to have a look, but it's not a very specific way of doing it. And so now PCR is the mainstay of looking at how to diagnose monkeypox. So in the UK, we use a dual PCR. So we look for orthopoxes and then look for monkeypox specifically. And that just gives us that extra layer of reassurance that we aren't missing anything. And within the UK, it used to be carried out by a single testing lab, but now it's done in at least 3, probably with a lot of NHS laboratories also doing testing, considering the availability of lots of commercial diagnostic kits now to be able to do that. And so how are we going to do that diagnosis. So the sample type and the timing of that sample is really important. Swabbing the lesions is always going to be the best way to do it, but knowing that we get asymptomatic infections or people who might not have large numbers of lesions, there are also other sample types that we can use. So rectal swabs can be really helpful. And upper respiratory tract samples can also be really helpful. Blood is less useful, and we should probably try and avoid using it, particularly it can be negative early in infection. So serology is available, but it is orthopox generic. So anyone who's had a smallpox vaccination or an infection with other orthopoxes may get a false positive reaction. So not particularly useful as a first-line diagnostic test. And the most important thing when we're doing this diagnosis is to consider all possible differentials. So not only testing for mpox, but looking for things like chickenpox or measles, or in those with genital lesions, also considering HSV or syphilis, because you can get dual infections as well as monkeypox specific infections. So trying not to discriminate when you're doing that testing. So how do we manage these infections? So those that have got mild to moderate infections, we can manage them at home. They can self-manage with fluids and analgesia with a daily virtual assessment. However, this is only for clade 2B. Any of those higher risk diseases do need to be managed more conservatively than that. So those with severe disease, so usually those that have got areas where there might be high sequelae, so or with really lots of high numbers of lesions, we do want to be managing in hospital. Although you can see that hospitalization rates are down, so around about 5.8% in the 2022 outbreak compared to nearly 50% of patients in pre-2017 who required management in hospital. So what treatments can we give to people? So as we've said before, primarily supportive, so fluids, analgesia. And one of the most important things to consider is that psychosocial impact with a disease like this, where we're wanting to restrict the spread in sort of a highly susceptible population. The psychosocial impact of isolation is really, really important, and making sure that these people have got access to appropriate support in managing that isolation, because these people could be isolating away from their families for a significant length of time while these lesions are present. In severe cases or in patients who are immunocompromised, we can use antivirals, although the evidence for their use for some of them is limited. So we have some of the nucleoside analogues, cidofovir and brincidofovir. So not specifically for monkeypox, more commonly used in things like adenovirus infection in pediatric bone marrow transplants, but they have been used with some success. Tecovirimat is probably the one that most people are commonly aware of, and does show some good efficacy in treatment of mpox disease, and has been used extensively during this outbreak. So we've got trifluridine as well. So that is more commonly used in ophthalmological mpox. And there is an isolated case report which suggests the use of vaccinia immune globulin, but it wouldn't be one that I would be recommending anybody use at any time. So let's have a look at some treatment doses. So tecovirimat, we're given it at 600 milligrams BD for 2 weeks, has been shown to be really effective, but you can get rare liver injury. So it's just about being mindful in people with pre-existing liver conditions. Cidofovir and brincidofovir, so cidofovir at a dose of 5 milligrams per kilogram, or brincidofovir at 200 milligrams, and they can be given either as a single dose or on a weekly basis. But with those drugs, liver injury is almost always reported, and so again, being really careful. And then, topical trifluridine in ophthalmic mpox, and we usually use that in conjunction with tecovirimat as an oral agent. So there has been a systematic review done to look at the treatment of mpox in patients. It is quite old now, published in February 2023, but I suppose the main take-home messages still do apply. So it looked at 71 individuals with tecovirimat used in 61, 7 in with cidofovir or brincidofovir in 3. Pretty much everybody resolved their symptoms with complete resolution in 83% of patients who were treated. And so yeah, it shows that these are effective agents that you can use, although, as it says, all of the individuals treated with brincidofovir had to stop their treatment because of liver injury. But this also did occur in 5 treated with tecovirimat. So, transmission. We have to remember that here we're dealing with a disease that was primarily confined to the African region. And so we are dealing with a highly susceptible population outside of those areas. And so our transmission routes are really important. So we've got 3 main modes of transmission. So we've got direct lesion contact, and this is why sexual spread is such an important thing. So it needs close contact to be able to transmit by direct lesion contact. And we've also got contact with contaminated fomites. So we saw in the UK that case of a healthcare worker who was infected from contaminated bedding. And interestingly, with that healthcare worker, they did receive post-exposure prophylaxis 6 days after contact, but still went on to develop disease. And the other, perhaps more well-known route is respiratory droplets from infected animals or humans, and that goes on to sort of any infected waste from animals could go on to transmit disease. So within households, we estimate that the transmission rate where people are unvaccinated, so unvaccinated against smallpox, that the 8% of people will pick up mpox infection. But as from that cluster that we saw originally in the UK in 2019, that rate can be higher. And so again, direct transmission is not noted, but rarely chains of transmission until 2022. And that was sort of exemplified by that prairie dog outbreak that I discussed earlier, where there was a lot, like 47 cases, but no person-to-person transmission. They all resulted from direct contact with prairie dogs. So when we think now we've got transmission, how do we stop transmission? And one of our sort of key areas is going to be making sure that those people who are infectious are not going on to infect other people. And one of the key things that we use to do that is looking at PCR positivity from various sample types. And this is something that's been gaining traction a lot over the last few years with SARS and things like that, using CT values to try and determine infectiousness. That's not been done with mpox infection, but what this slide I'm trying to demonstrate to you with this slide is that the sort of natural history of monkeypox is not linear. So each of these graphs shows diagnostic testing for a particular patient over time per sample type and their cycle threshold value for each of them. And the take-home message from this is you can see that they are wavy. So if you look at patient 3, for example, they are going from positive to negative, left, right, and center. And so it's being careful about how you decide to release somebody from isolation. And the other poignant patient here is patient 4. So if you can see along the bottom, from around about day 29, they're negative in blood. Their lesion PCR positivity has come down. They are not showing any positivity in their upper respiratory tract samples, but then all of a sudden at day 73, their respiratory tract sample is positive again. And that patient will have likely been released from isolation. So it's just being mindful, not only as sort of healthcare professionals, but also getting across to the patients that we're dealing with that it is important to maintain hygiene, etc., once we are released from isolation to try and reduce that onward spread. So how can we prevent? So again, I feel like saying this a lot, but good hygiene is key. So minimizing contact with lesions, and we can do that by providing patients with dressings to cover lesions, and also isolation of cases. However, we can give pre-exposure or post-exposure prophylaxis with smallpox vaccine. So studies have suggested that this is around about 85% effective against giving the people developing onwards disease. And this has been shown as well by people with a history of smallpox vaccine in childhood do tend to have reduced disease severity. So we've got newer third generation smallpox vaccines, which is great because they're replication defective. So they don't go on to cause disease in people. And they're usually given on a 2-dose schedule. So these will vary depending on whereabouts in the world you are, but one of the most common is the MVABN, which has different label names, so Invenex or Genos. So we are giving that on a 2-dose schedule, 28 days apart, depending on whether or not you have been vaccinated against smallpox in the past. So for most people, it's going to be a 0.5 ml subcutaneous or intramuscular injection. However, where there are supply constraints, it has been shown that a 0.1 ml intradermal injection in those that are previously or completely immunocompetent with no previous vaccination history is as effective as that dose. So it can be good for allowing you to spread out the vaccinations that you give. That particular dosage is not suitable in the immunosuppressed or in children, but it can be given in individuals over 18 years who have had a previous smallpox vaccination to boost their immunity. So who are we going to give this to? So the UK Committee of Vaccination and Immunisation recommend that everybody who is a laboratory worker at risk, so this is not your sort of typical laboratory workers, but those who work in areas where they are likely to come into contact with Mpox containing samples, and those who work in high-risk healthcare settings, so high-consequence infectious diseases units. When we are in an outbreak situation, we can expand that pre-exposure prophylaxis to include people who work in sexual health units or in wards that are specifically dealing with Mpox patients. And we can also extend that out to people in the gay, bisexual, men who have sex with men community who are at high risk of infection. And that is only in an outbreak situation, just to try and conserve smallpox vaccine, which is not available in high numbers. For post-exposure prophylaxis, we can give that at any time to anybody who has a high-risk exposure, either through contact with a case or through occupational exposure. And that should be given within 4 days. However, in those that are at higher risk, such as pregnant women, children, or immunocompromised patients, we can expand that out to up to 14 days. That's not going to necessarily stop them becoming infected, but what we hope is that it would reduce the number of lesions and the disease severity. So for those that are at high risk, we can consider boosters, and how often we give those will depend on their risk, and that can be given between 2 and 10 years post initial vaccination. So as I've just alluded to, so even getting post-exposure or pre-exposure vaccination doesn't stop you from getting infection. So this paper published in The Lancet Infectious Diseases looked at 37 gay and bisexual MSMs and found that 7 of them did have monkeypox reinfections and 29 had infections that occurred despite having 2 appropriately spaced vaccines. But as I said, what they did find is that they had fewer lesions, little mucosal disease, and their pain was significantly less. And they didn't require antivirals as often as other patients did. And importantly there as well, no bacterial secondary infections were found, which was one of the most common reasons for admission to hospital for some of the other studies that have been published. So now I'll just move quickly on to a very swift case of Mpox that we dealt with locally. So we had a 33-year-old male admitted in status epilepticus. So he had a history of a traumatic brain injury 2 years prior, which meant that he'd spent 2 months in hospital having significant rehab. He'd been released with Keppra to control intermittent seizures as a result of that traumatic brain injury. On admission, he had returned 2 days prior from a 2-month stint in Nigeria, where he'd been attending the funeral of his grandmother. on attending church, he had suddenly decided to stop taking all of his medications, to stop smoking, drinking, and taking recreational drugs, in the hope that his body would be able to heal himself. He had reported a 1-week history of lesions to his face, for which his sister, who was a GP in Nigeria, had prescribed ciprofloxacin. And there was some question as to whether or not this might be due to herpes simplex virus, as he'd had a recent unprotected sexual contact with a female whilst in Nigeria. So on admission, he was actually a very, very poorly gentleman. He'd required intubation, was severely hypertensive and had a GCS of 3. He did have significant lymphadenopathy and his lactate was greater than 20. During his time while he was being assessed in ED, he developed a new pustule to his left arm alongside those lesions on his face that had been previously documented. He was transferred to the local intensive care unit before being discussed with our local infectious diseases team. The initial investigations that were recommended by the infectious diseases team were as follows, so covering all sorts of possible causes for infectious diseases in line with his recent travel history to Nigeria. He was assessed for viral hemorrhagic fever risk and found to be, or thought to be, low risk at that time. So on day 2, after his transfer to intensive care, he had improved in terms of his metabolic acidosis, and his seizures had stopped, but he was still intubated, requiring renal replacement therapy and on vasopressors at this time. So again, was still quite poorly. His CT head showed serious, extensive ischemic changes, and he ended up with compartment syndrome in both forearms, which required bilateral fasciotomies to be done in the intensive care unit. So the working diagnosis at that time was probably status epilepticus, secondary to stopping his epilepsy drugs, compartment syndrome from prolonged seizures, but also possible mpox, encephalitis. So the decision was made to transfer him to a specialist airborne high consequence infectious diseases unit for ongoing management. So his monkeypox PCR was positive from penile lesions, from lesion on his arm, and facial lesions. And that was later found to be a clade 1 virus, not the clade 2 virus that was circulating at the time.
Yeah, excuse me, Dr. Ima, can I ask you to conclude your presentation in 1 minute to allow time for the participants to ask or to comment?
No problem. I will just finish the case and then I'll finish there.
Thank you.
So the decision was made to treat with 2 weeks of tecovirimat plus broad-spectrum antibiotics. So he was given 600 milligram BD, and his skin lesions did resolve, and we had no other significant microbiological findings. Whilst he was on the unit, he required 2.5 weeks of renal replacement therapy. He had to have a percutaneous tracheostomy due to a prolonged wean from his ventilation. And despite his optimization of his anti-epileptics, he did have ongoing seizure activity, and his fasciotomy wounds were slow to heal. He then went on to develop a significant right eye erythema, and it was found that he actually had a monkeypox keratitis with corneal ulceration. And he was requiring 6 different eye drops every 2 hours, which were required to be given under HCID conditions. After 6 weeks in the airborne HCID unit, he was referred back to our regional ID unit, where he had ongoing issues with monkeypox keratitis and corneal ulceration. He was recommenced on tecovirimat at 600 milligrams BD and trifluridine eye drops at 9 drops per day. However, his ongoing isolation did lead to significant mental health impacts. Despite having therapies, his eye condition continued to deteriorate and he continued to be mpox PCR positive. The possibility of tecovirimat resistance was postulated, but we were unable to confirm that, and it was not felt appropriate to add in other agents at this time. So we continued on with tecovirimat and trifluridine. Despite actually having made no change to his medications, he did start to improve after about 1 week later. All of his antiviral medications stopped after 21 days, and he was discharged from inpatient care after 12 weeks, although his eye had not completely resolved he was allowed to go home with custom-made dressings to allow him to leave, as it was felt that his mental health was taking quite a significant knock by being isolated inpatient for 12 weeks. So January 2024, his keratitis is still undergoing follow-up. It's not completely resolved and he hasn't regained all of his vision. His fasciotomy wounds look great, but he does have ongoing mental health concerns. And this is just, again, to get home that these patients that are being isolated do need to be properly looked after in terms of their mental health. And so I will stop there.
Yeah, thank you so much, Dr. Ima, for the insightful presentation. Very informative. So now the floor is open for questions and comments. Please use the chat box. And while the audience thinking about to raise questions, so just let me start with myself. Based on your presentation, what I have noticed that the peak number of the cases usually around the summertime. So is this like somehow virus related, or it's human behavior related, in a sense that like the virus is more active during the summer, or it's usually because the people during the summer are more likely to socialize, to entertain, and to be exposed. So can you comment on that one?
Yeah, so I think it's definitely human behavior. I think that summertime, yeah, I think there is a lot more socialization. There are a lot more big events going on, and so I think that there is more opportunity in the summertime for people to spread what is now sort of a disease that is spread through close contact, and we see that sort of thing with other sexually transmitted infections as well. So yeah.
Mm-hmm. So it's not related to the virus that's more likely to be active during the warm weather. It's related to the human behavior in terms where they're more likely to socialize, to interact with each other, and to be exposed to the infected people, and even to be exposed to the animals, right?
Yeah, I think so. But I think that now, for us in particular, outside of Africa, I think animals are no longer, I wouldn't consider animals a significant reservoir of infection anymore. And although we call it a zoonotic disease, that perhaps that needs to be reconsidered. Certainly for the sort of clade 2B viruses, that lineage B1 that's been circulating everywhere else, I think we should consider it less of a zoonotic disease now.
Yeah. So the other comment or the question is based on the information that you provided. So there's a lower risk for the infection in somehow a higher risk for the infection in unvaccinated household. I didn't get your point about which vaccine. What do you mean by the unvaccinated household?
So this is households that have had smallpox vaccination. So yeah, a significant higher risk of transmission where there are people within the household that have never been vaccinated by smallpox. And so it's about lowering the risk by making sure that those people who are exposed are able to access post-exposure prophylaxis. So are able to access those vaccinations within a timely manner as well.
So in that case, there is a kind of cross protectivity between pox vaccination and monkeypox infection.
Yes, okay. Absolutely. And I think that is why we have started to see cases increase sort of once smallpox was eradicated and we stopped vaccinating people against smallpox. And that's why you used to see sort of in the early days of outbreaks in the Democratic Republic of Congo, those outbreaks were occurring in children rather than older people, because the children would no longer have been vaccinated against smallpox once it was eradicated, and that vaccination program stopped.
Yeah, thank you so much. So let me check the chat box if we have any questions. So Dr. Azhar, do we have any question or comment from the audience?
Yes, Dr. Michael, Dr. Rami, there is a questions from Muhammad Libreki. If you open the question and answer at the bottom. So can you see the question? You would like me to ask it?
Can you ask the question, because
okay.
I'm not...
So Dr. Emma, thank you so much for very interactive and very informative presentations. There is a questions from Mr. Muhammad Libreki asking that, saying first, thank you for the interesting presentations, and is there any rate of asymptomatic carriers different compared to other groups? So he's saying that, I'm not sure if the question is correct, but how did we know that the main transmission in the case of the global monkeypox outbreak in 2022 is sustained through human-to-human contact and not animal, because he's rarely see data on animal contact by gender sexual orientations.
Yeah, so thank you for that. So I haven't got figures that show the rates of asymptomatic carriage in any patient group. It is just postulation that that is most likely what is happening. We have seen lots of cases of people who are contacts who have been tested, who have then been found to be positive through respiratory tract secretions and those things without the presence of lesions. And so we take that to be asymptomatic carriage. And the fact that there was sustained transmission within the community before we were detecting people with lesions, so we were picking up cases in people who had not had any foreign travel, would go to suggest that there are people who either have very mild disease or asymptomatic disease, but I don't think there's been any studies to look at the sort of rates of that, and I'm not sure how easy that would be to do either. So, and then the next bit was about how do we know it was human-to-human transmission rather than animals. And so when these cases and outbreaks were occurring, there was significant sort of public health intervention, which did extensive surveys and things of people's activities and exposures, and they were all associated with attendance at these same events, etc., that would suggest that this was human-to-human transmission and not animal transmission. I think in the UK it is less likely to be animal transmission because most people do not have much in the way of animal contact apart from pets at home. So
yeah, thank you so much. I actually don't see any more questions or comments. So do we have, Dr. Azhar, do we have?
And because of the time limit, let's...
Yeah.
So I'm happy if anybody has any questions that they don't want to answer now, but would like to email to me, and then yeah, you can feel free to please email me on the address that's on the screen now.
Yeah,
yeah,
definitely.
thank you so much.
Last question, Dr. Ima, from my side. Like, do you recommend carrying out sero-epidemiological studies to assess the susceptibility of local population to monkeypox?
So I don't think that the serology testing that we have routinely available is good enough to support that. And also with us knowing that even receiving 2 doses of appropriately spaced vaccination or having prior infection doesn't mean that you won't become infected again. I'm not sure that that is a cost-effective way of looking at things.
Okay, thank you so much. So like to close this webinar, so I would like to extend my sincere gratitude to Dr. Davies for accepting our invitation and delivering an outstanding and highly valuable presentation. Thank you, Dr. Davies. I also wish to express my thanks to everyone who have been involved in making this webinar possible, including the management of our college, the College of Medicine and Health Sciences, and the university. Special thanks go to Professor Michael Griffna, the Director of the Institute of Public Health, Dr. Effat, Dr. Azhar, Mr. Ismail, Mr. Al-Sajir, Mr. Amino, Ms. Bayan, Ms. Khadija Al-Blushi, and Mrs. Mariam Al-Niyadi for their significant contribution and support in organizing and preparing all IBH webinars. A heartfelt thanks to our audience for their active participation in the webinar. Please remember to fill out the evaluation linked in the chat box to receive your CME certificate. Stay updated and follow us on our IBH social media accounts at UAEU-IBH. You can access the recordings of all our hosted webinars on our YouTube channel, Institute of Public Health-CMHS. We eagerly anticipate your future participation in our upcoming webinar, which will be taking place on 27th next month, February 2024, and titled AI in Healthcare Benefits and Drawbacks. So once again, thank you, Dr. Ima. Thank you for all the audience. Take care, stay safe, and goodbye.